All right, I think we're going to go ahead and get started here. If there are those out there that can hear us but can't see us, this presentation is being recorded, and the presentation will be available for download or email afterwards. So if you are having some technical difficulties, you will be able to view this presentation later. Welcome to the first of several webinars that we're going to be hosting on a variety of topics. And the first one we're going to be looking at today is what we're calling weathering the storm, what to expect in the coming year for employee benefits. Just a couple of disclaimers here. This presentation is not meant to be any type of legal advice, any type of tax advice, the final word on health care reform, because it's always changing, or any type of political endorsement of any kind. I am your presenter, Wes Campbell. I think I know just about everybody that's on this webinar with us here today, but for those that don't, I've been with SEBO since 2002. I am a charter benefit consultant since 2011, meaning I specialize in alternate funding design. My job around here basically is to maintain our client relationships, develop new relationships, and review new products that come out that we think might be good for implementation in our market segments. And so many of you I've worked with on your renewals, and that's a large part of what I do here. Just a couple of housekeeping items. We will be doing a few webinars throughout the rest of the year, so please make sure you check back on our website for further dates and topics. Again, this webinar is being recorded and being uploaded to our website. If you have questions, feel free to use the chat box. We will try to get to as many as we can if there are questions throughout this, but we may respond to some afterwards, time permitting. Please also make sure you're connected to us on Facebook and Twitter. We do post quite a bit of information there, try and get things out to the field in real time. So what's our agenda for today? We are going to highlight the Affordable Care Act's first year, really not its first year, but its first full year of implementation and being something that we're all managing. We're also going to look at what some of the coming changes are going to be for 2015. And just briefly, we're going to look at some alternate funding concepts that some of our customers are using in the wake of the Affordable Care Act. So what is the biggest challenge in today's employee benefits environment? I'm sure all of you may answer that one way or another. Some may be similar. Some may have different concerns than others. But after talking with many of the people that we work with, we've narrowed it down to just a couple things. We think the answer is navigating the regulations and staying compliant, managing the increased costs associated with the Affordable Care Act, as well as managing the complications that can arise from its implementation. So what is healthcare reform? It's got many different names: healthcare reform, Obamacare, the Affordable Care Act, PPACA. The Paycheck Protection and Affordable Care Act was actually passed back in March of 23rd of 2010. But it really wasn't until January 1st of this year that the full provisions went into full effect, ushering in many of the new reforms and new health coverage options that are impacting Americans across the country. We're going to look at some of what this year's provisions were as we kind of review what has gone into place so far. Many of those provisions impact the marketplace, some impact eligibility, and others impact cost in the form of new fees associated with healthcare reform. One of the most major provisions that was put into place on January 1st of this year was the implementation of the health insurance marketplaces, also known as exchanges. Public health insurance marketplaces are available in every single state in the U.S. Some have their own exchanges. Others work within the constraints of the federally facilitated marketplace like we do here in Ohio. These government-run online shopping hubs are available for individual consumers and small businesses right now with fewer than 50 full-time employees to compare plan offerings and buy health insurance. Now, the individual exchange is up and running, federally facilitated exchange here in Ohio. The SHOP, which is the small health options, small employer health options exchange, we expect to be open for January 1st of 2015. As you can see in the graphic here, we've indicated some of the key dates moving forward. For example, the open enrollment for 2015 will begin November 15th of this year and run through February 15th of next year. Okay, that will be the open enrollment period for those who don't have some sort of a special qualifying event, meaning a change in income, a change in family size, something of that nature. Those types of special qualifying events would give you a special open enrollment period. By January 1st, it is expected that the exchanges are going to be financially self-sufficient, including the federally facilitated exchange, in large parts the fees that we'll talk about a little bit later. January 1st of 2016, we expect that the small employer or SHOP exchange will be open to employers with up to 100 employees rather than just 50 initially. And then in 2017, the group exchange may actually extend all the way to large employers as well. But those are things that are kind of still being put in motion. The most commonly reported in the news provision of the Healthcare Reform Act was the individual mandate. This is the mandate that under the law that all people must have what we call minimum essential coverage starting January 1st of 2014 or pay a penalty unless they have a special exception. And that penalty, as we'll see, is something that is based upon how many months you are without coverage. You typically have minimum essential coverage if you have a government-sponsored plan, an employer-sponsored plan, or an individual plan through a traditional insurance carrier. Individuals in the state of Ohio right now can choose to buy health insurance on or off the state insurance exchanges that open in 2014, and some people can also get a federal premium assistance on an exchange. That's the advantage to purchasing your insurance through the exchange, is you are going to qualify for a subsidy. If you're somebody that does not qualify for a subsidy, you would typically purchase your policy outside of the exchange, typically a plan that would look exactly the same as the one inside the exchange, but typically the plans that are outside the exchange tend to be a little less expensive. So what are the penalties for those who do not carry minimum essential coverage? Well, the IRS has set them up as follows. The monthly tax penalty will be 1/12 of the greater of, in 2014, $95 per uninsured adult in the household, capped at $285 per household, or 1% of the household income over the filing threshold. And we'll talk about exactly what that means here in a second. In 2015, the penalty rises at $325 per uninsured adult, capped at $975 per household, or 2% of the household income over the filing threshold. And then in 2016, the penalties ramp up to $695 per uninsured adult in the household, capped at $2,085 per household, or 2.5% of the household income over the filing threshold. So let's take a look at it as an example of what that means. We have here the example of Jim, an unmarried individual with no dependent, who does not have minimum essential coverage for any month during 2014 and does not qualify for any type of an exemption, be it religious, be it anything that's been granted by the federal government. Jim has annual income of $40,000. His filing threshold for 2014 for a single individual with no dependents is $10,150. So we would start by calculating what is 1% of his household income over that filing threshold. So we subtract the filing threshold of $10,150 from the $40,000 of household income. What's left over is $29,850, and 1% of that is $298.50. If he was below the filing threshold, his flat dollar amount penalty would be $95. Now, no one can pay a penalty any higher than what the national average premium is for a bronze level plan, which in 2014 is $2,448. So because his 1% penalty at $298.50 is more than the $95 penalty for flat dollar and less than the $2,448 premium for a bronze level plan, the $298.50 is what his penalty would be for the year in 2014. And that equates to $24.87 per month each month that he is uninsured. Jim will make his shared responsibility payments for the months he was uninsured when he files his 2014 income tax return, which is due obviously in April of 2015. All insurance plans that are considered to have minimum essential coverage must carry essential health benefits. And those essential health benefits, as laid out by the Affordable Care Act, are as follows: ambulatory patient services, emergency services, hospitalization, maternity and newborn care, mental health and substance abuse disorder services, including behavioral health treatment, prescription drug coverage, rehabilitative and habilitative services and devices, laboratory services, most importantly, preventative and wellness services and chronic disease management, and lastly, pediatric services, including oral and vision care. So for your health insurance plan to be considered minimum essential coverage, it must cover these categories. Now, that isn't to say that these categories are covered in their entirety. A lot of it depends on your individual insurance plan, what type of deductible you have, what kinds of copays you have. Maternity may be covered, but you may have to meet your deductible before it is covered. Building upon that, these essential health benefits cannot have any dollar limits on them. So as it says here, reform says that plans of all sizes that cover benefits designated as essential health benefits, including self-funded plans, must cover these benefits with no annual limits or lifetime maximums. Now, typically, a lot of plans didn't have annual limits, but you did see plans that had maybe a $1 million or $2 million or $5 million lifetime maximum. Now those lifetime maximums are unlimited, as are the annual limits. So once you've met your deductible, there is not a point at which a qualified plan can stop paying for those services. Another big advent with the Affordable Care Act was the elimination of pre-existing condition limitations. Beginning with the first plan year, beginning on or after September 23rd of 2010, individual and group health insurance plans were prohibited from denying coverage to anyone under the age of 19. And that's how this law was phased in. That ban included benefit limitations or coverage denials. Beginning January 1st of this year, nobody can be denied coverage based on any type of pre-existing condition. If you are in the individual or the small group markets, you cannot be denied a quote based on any type of pre-existing condition. Your insurance carriers aren't even allowed to ask you what your conditions are in group insurance contracts. They're only allowed to rate you in the individual and small group markets based upon your location, your census, and how many smokers you have. Now, we'll talk about the reason why we still collect medical information from employers a little bit later. The legislation also requires the coverage of routine patient care costs related to clinical trials. But luckily, we expect that the financial impact of this to be relatively small, as many of these expenses associated with the clinical trials are already covered. There are also a couple of eligibility-related provisions, guaranteed availability and renewability and waiting periods. Each carrier offering fully insured health insurance coverage in the individual or group market must accept every individual and group in that state that applies for coverage. So again, if you're applying for traditional group insurance through Anthem, Aetna, United Healthcare, Assurance, so on and so forth, they have to provide you a quote. Okay? In the past, they could decline a quote if they didn't like the way your health conditions look. So that's what we mean by guaranteed availability. The carrier must also renew or continue the coverage at the plan sponsor or individual's choice. That's what we mean by guaranteed renewability. An insurance carrier can't cancel you in the middle of the year if your claims are running poorly or for any reason whatsoever. One of the most common questions we get is, well, can I break my contract early? Well, yes, you can break your contract at any time. It's quite simple, actually. All you have to do is not pay your premium, and they'll cancel the contract for you. But they are obligated to maintain your coverage for as long as you keep paying your premium. Grandfather plans, which are being phased out, are exempt. We don't see a lot of grandfather plans still in existence at this point. While we're on the topic of renewals, one of the most common questions we receive when dealing with a new group or even moving a group to a new carrier is, well, what will my renewal look like next year? That's simply impossible to answer, but we are starting to gather more information. Renewals for ACA plans, meaning individual and small group plans, will be based on that carrier-specific block of business within the state. Now, if you're a large group, you'll still be rated based on how your claims are running. But in the small group market, it will be based upon the block of business within that state. Now, we are starting to see our first information for 2015. PricewaterhouseCoopers has recently released a report where they looked at the average increase expected in all 50 states. They haven't collected all the information yet, but Ohio's information, while limited, is starting to trickle out. And the average premium increase we are expecting to see in the individual and small markets in Ohio is 12.1%. You can see on there the average 2015 premium is expected to be around $373. Now you have to keep in mind your premium may be more or less than that. This is just an average. This includes all plans that are $6,000 deductibles that are out there. This includes all plans that are $100 deductibles. So this is meant to just be an average within the individual and small group markets. Again, if you're in the large group markets, your increase will be what your increase will be based on your claims experience. Okay, but this is some of the first information that is starting to come down as to what we can expect for next year. And as we have more information, we expect to be sending that to you. Rates for 2015 should be starting to be filed here very soon. We also mentioned waiting periods. Within reform, group health plans and group health insurance carriers can't require an insurance coverage waiting period of more than 90 days. As long as an employee is able to elect coverage, it becomes effective on or before the 91st day after the start of the waiting period, the requirement is considered to be satisfied. And keep in mind, when we say 90 days, we do mean all calendar days, including weekends and holidays. Lastly, on the topic of new provisions of healthcare reform, we have fees that are associated with healthcare reform. The health insurance industry fee, the reinsurance assessment fee, and what we call the PCORI fee. The health insurance industry fee is a fee on health insurers, including HMOs, and it's based on each insurer's share among all health insurers of U.S. health risks. It starts at $8 billion in 2014 and increases year over year before reaching $14.3 billion in 2018. Most insurance carriers are passing these fees on to those that have the insurance contracts, the individual contracts and group policies. Okay. The second fee is the reinsurance assessment fee. This is also meant to help fund the Patient Protection Act. This assessment on health plans will total $25 billion, which will be collected over a 3-year period from 2014 through 2016. The majority of the money will be used to fund a reinsurance program, which is intended to lessen the impact of adverse selection in the individual market. And what that means is, for those carriers that are participating in the individual exchanges, they are required to offer an insurance contract to anybody that applies. So somebody who may have been denied coverage in the past because of an expensive condition can now get coverage. And so this reinsurance program is meant to soften the blow for those insurance carriers that are covering people with high claims. And this assessment applies to both insured and self-funded commercial major medical plans. And again, these fees are typically being passed on to those that have the insurance contracts. Lastly is the PCORI fee, the Patient-Centered Outcomes Research Institute fee. The Affordable Care Act imposes a fee on insurers of specified health insurance policies and plan sponsors of self-insured health plans to help fund this Patient-Centered Outcomes Research Institute. The fee, required to be reported only once a year on the second quarter Form 720 and paid by its due date of July 31st, is based on the average number of lives covered under the policy or plan. If you are a group that has a health reimbursement arrangement administered through SEBO, we hope you file this fee this year and last year. If you are a group that has traditional fully insured plan through a traditional insurance carrier, this was typically built into your rates and paid for you. For issuers of specified health insurance policies or plan sponsors, the fee for this year is $2 multiplied by the average number of lives covered on the policy for that year. So again, if you have an individual plan or you have a small group contract, these fees are built right into your premium. You don't typically even see them, but they do represent what we think is a 3 to 6% increase in the cost of most policies. If I've come out and met with you about your renewal this year, I've probably mentioned to you that several percentage points of your increase is probably as a result of these fees being passed on to you as the group insurance holder. If you're a large group, typically these fees are broken out. Some carriers even bill them separately for large groups. But again, they are being passed on to the groups. So what has the impact of the Affordable Care Act been in Ohio? Well, we estimate that the ACA could extend coverage to 1.5 million uninsured Ohioans. That's not to say that 1.5 million people got insurance that didn't previously have it, but that's how many people were potentially able to get insurance where they may not have been able to in the past, which is a fantastic thing. Ohio's controlling board, at the direction of the governor, approved the state's implementation of the Medicaid expansion, which means over 285,000 Ohioans have enrolled in coverage as a result of this Medicaid expansion. As we mentioned before, Ohio is one of the 27 states in which the federal government has set up and is running their health insurance marketplace. And the Affordable Care Act also provided for the establishment of what we call consumer-operated and oriented plans, also known as co-ops. There's one co-op here in the state of Ohio called InHealth Mutual. If you are a small group, we receive quotes from InHealth Mutual for your group, just like we do from any other health insurance carrier. Okay. This map just shows which states have which types of marketplaces or exchanges. As you can see, Ohio is one of several that has the 27 states actually that has the federally facilitated marketplace already in place. The Navy states are the states that set up a state-based marketplace, some of which already had it in place. Massachusetts was famous for their Mass Care program, which was a state-based marketplace that has been in effect for several years. Those that are in the royal blue have a combination of the two. Might want to mention as well that this information comes from the Kaiser Family Foundation website, and we find them to be an invaluable resource when looking for information on the Affordable Care Act. Many of you I've shown their subsidy estimator tool, which we think is a very handy tool. So what can we expect in 2015? The employer mandate continues to be phased in. There will be large employer reporting requirements and also minimum essential coverage reporting for insurers and self-insured plan sponsors. So we'll talk about those right now. Employers with 50-plus full-time employees or full-time equivalents must offer medical coverage that is affordable and provides a minimum value the full-time employees that and their children up to age 26 or face penalties. That's the definition of the employer mandate. When we say it's affordable, we mean that a plan cannot cost an employee any more than 9.5% of their gross income, their household income. And when we say it must provide minimum value, it must have an actuarial value of at least 60% and provide those essential health benefits. I think just about everybody on this call has a contract that meets those requirements. This employer mandate, though, is being phased in, and this chart shows how. For groups under 50 full-time employees or full-time equivalents, the employer mandate does not ever apply. This year was the year that it was supposed to start applying for groups over 50 full-time employees. However, that has been delayed to 2016. Employers in 2016 with between 50 and 99 full-time employees will be required to offer coverage to 95% of their full-time employees in dependent age 26 or face penalties. For employers with 100 or more full-time employees, employers must offer coverage to at least 70% of full-time employees starting this year and 95% in 2016. In 2015, we are being told that employers with 50 to 99 employees will need to certify that they are not reducing the size of their workforce to stay under that 100 threshold. Now, we don't know exactly how that reporting is going to be handled yet, but that's just what is written into the IRS's clarification, as well as a clarification that was handed down by the Department of Labor. How do the penalties affect employers? We think this chart kind of explains it very easily. First of all, do you offer coverage? If you offer coverage, then you don't have to face the first penalty. If you do not, the penalty is $2,000 per full-time employee, and it only kicks in if one full-time employee receives a federal premium assistance for marketplace coverage, or so in English, receives a subsidy. In 2015, employers will receive a credit for the first 80 employees. After 2016 and beyond, it will be a credit for the first 30 employees. So next year, if you're an employer with 100 employees right on the nose and you do not offer coverage, if one employee goes and gets a subsidy, you will have to pay a penalty of $2,000 per full-time employee minus the first 80. So if you have 100 employees, you pay a penalty on 20 employees. So it'd be a $40,000 penalty. If you do offer coverage, the next question is, does that coverage provide minimum value? Does it cover those essential health benefits? Is it at least a bronze level plan? And is the coverage affordable? Does it not cost any employee, the lowest paid employee, any more than 9.5% of their household income? If you answer no to either of those questions, the penalty is $3,000 per full-time employee receiving a tax credit, or $2,000 per full-time employee minus the first 80 in 2015 or first 30 in 2016 and beyond. We do have a penalty calculator, so if you're worried about how this could potentially affect you, please just let us know and we can walk you through those steps. Again, this will only apply to employers over 100 starting in 2015. It will apply to employers with over 50 employees starting in 2016. Large employer reporting. There's quite a bit of reporting that will be required for large employers. Starting with health coverage offered in 2015, employers with 50 or more full-time employees and or full-time equivalents must provide the IRS and their employees information about the coverage offered during any given calendar year. The 2015 reporting will be due in early 2016 in tandem with other tax filing documentation. The information will confirm the employer's compliance with the employer mandate, including whether the employer offered all full-time employees and their dependents the opportunity to enroll in minimum essential coverage, and if that coverage met the minimum value, and if that coverage was affordable. Okay? So this is something that will be put into place for plan years starting in 2015 and will not be needed to be reported until 2016. either SEBO or your tax professional will be able to work with you when the time comes for this. There will also be required around the same time minimum essential coverage reporting. Starting with 2015 health coverage, insurers and employers who self-insure their group health plans must provide the IRS and covered individuals with information about minimum essential coverage. This information will confirm each person's enrollment for each month of coverage as required by the individual mandate. So as you can see, the first large employer reporting was going to cover the employer mandate. This minimum essential coverage is going to cover the individual mandate. This reporting requirement applies to all size employer plans. The 2015 reporting is first due in early 2016 in tandem with other tax filing documentation. There will be specific data required in this IRS reporting. Using the IRS forms will be the best way to ensure insurers and employers are providing all the required data. If you have a group health insurance contract through a traditional health insurance carrier like an Anthem, an Aetna, Medical Mutual, so on and so forth, this will most likely be handled for you by the carrier. But some of the specific examples required in this reporting will be the name and address and EIN of the reporting entity, the name and address and Social Security number of each responsible individual, the name and Social Security of each covered individual, and the months of coverage during the calendar year. Again, this is how the IRS will regulate the individual mandates. Lastly, one of the complications arising from the Affordable Care Act that will be phased in will be the health plan identifier. The Department of Health and Human Services will require that all plans obtain a 10-digit unique identifier from a government-sponsored agency. This health plan identifier is intended to streamline electronic transactions between carriers, administrators, healthcare professionals, and financial institutions. So this law requires self-funded employers or group health plans to obtain their own health plan identifiers. Again, fully insured plans do not need to do anything to comply with this regulation, as the insuring company will have its own identifier. So again, if you have a small group contract or a large group contract through Medical Mutual, Anthem, Aetna, so on and so forth, this will be handled for you. If you have a self-funded contract, though, you will need to obtain your own health plan identifier, and we will work with you on that. Here are the dates for the compliance of that. Health plans with annual receipts of $5 million or more will need to obtain their health plan identifier by November 5th of this year. Small health plans that are self-funded are those with annual receipts of $5 million or less will need to obtain their health plan identifier by November 5th of next year. And then all plans that generate electronic transactions are required to use these identifiers in those transactions beginning November 7th of 2016. Employers who distribute 250 or more W-2s for any tax year need to also include the value of applicable employer-sponsored coverage on each employee's W-2. This is not considered taxable income. It is for informational purposes only. Employee premiums can still be made on a pre-tax basis. And what's important to note here is that if you are an employer that has seasonal employees or something of that nature, this requirement applies if you distribute 250 or more W-2s. So, for example, a high turnover employer with 200 employees may send out more than 250 W-2s and will consequently need to include this information. This is one of the provisions that was put into place a couple of years ago, but we still need to be mindful of to help support the administration of the marketplaces and to notify people of what their options are. Employers with more than 50 full-time employees must provide a one-time notice of coverage option to all employees, even part-time employees, regardless of whether or not coverage is offered. There was a sample notice that we sent out to all of our employers to send out to their employees. This notice helps build awareness of the health insurance marketplaces and any applicable employer-sponsored health coverage. If you complied with this, which I'm sure everybody on this call did, you were asked to send out this single statement, this form, by October 1st of 2013. It's important to note, though, that you want to continue to make that form available as a part of your new hire process. We find that that is maybe one area where employers are not staying as compliant as they should be. So lastly, we just want to talk about a couple of things we can try and do to offset some of the challenges, focusing mostly on the increased costs. And some of these topics will be covered in future webinars. Right now, we are doing a lot in alternate funding concepts, meaning health reimbursement arrangements, health savings accounts, partial self-funding, which some of you already are participating in, and we're doing a lot in the wellness arena as well. A health reimbursement arrangement is a notional account that employers use to reimburse employees for their qualified health care expenses. So this is money that is only paid by the employer if and when claims are incurred. Funds do not accumulate in a separate account, but rather employers pay only after the employees incur expenses. Conversely, a lot of employers are looking at health savings accounts, or HSAs. I'm sure you've heard that acronym before. That's actually not insurance, but is a financial account established by an individual to pay for qualified medical expenses. The HSA is linked to a qualified high-deductible health insurance plan, and anyone can contribute to it, whether it be an employee, a spouse, an employer, so on and so forth. People get confused thinking an HSA is a type of insurance. Really, it's the qualified high-deductible health insurance plan behind the scenes that is the insurance. The HSA is simply just a financial account that's used to pay for qualified medical expenses. Partial self-funding is one that we're using with a lot of small and large employers. Partially self-funded policy is a health care plan in which the employer assumes partial financial risk for providing health care benefits to its employees. The employer decides on a plan of employee benefits, which can be similar to what's currently being offered, or you can create whatever type of benefits you'd like. There's a lot of flexibility in partial self-funding. Rather than obtaining medical coverage from an insurance carrier, the employer elects to fund the risk up to a certain level, at which point reinsurance or stop-loss insurance carrier is brought in. The stop-loss insurance is designed to limit the employer's loss to a specified amount on each employee to ensure that large or unanticipated claims do not upset the financial integrity of the self-funded health care plan. The amount of risk to be insured is a function of the employer's size, nature of their business, financial experience, and tolerance for risk. What's nice about partially self-funded contracts that we're seeing in the marketplace now is they're typically being written to look exactly like traditional insurance plans. The partial self-funded plans that we have written are written with a premium that is quoted, and the premium will never be more than that which is quoted. There's only the opportunity to potentially receive money back. And we talked about the elimination of pre-existing condition limitations at the beginning and how health insurance carriers can't ask any medical question. In these partially self-funded situations, insurers can ask for health questionnaires. They can ask for individual employee applications. So we find that these partially self-funded plans can be a good fit for employers that want to continue to be rated on their own merit rather than join the community-rated system. If your group is healthier, if your group is younger, you may be a good fit for partial self-funding. We have had a variety of clients, and I know there's quite a bit of library folks on this call. We've had quite a few libraries go with partial self-funding, and in fact, we just got word that because of our relationship with the OLC, Aetna is the first name brand carrier that is joining the partially self-funded marketplace, and they will be offering their partially self-funded plans to libraries. We had some other carriers that were not offering their partially self-funded plans to libraries because of their lack of inclusion of things like the mental health parity and substance abuse parity. But we'll have more information on these types of things in future webinars. Wellness is the other area that we think is very, very important, especially given the change in climate in healthcare. Employee wellness programs are an effective method to promote health and wellness amongst the members of your staff. These programs will encourage awareness of health-related issues, improve morale, and oftentimes reduce costs of health care throughout your corporation or your entity. According to the Corporate Wellness Magazine, every $1 invested in employee wellness programs yields roughly $4 in savings through reduced sick days, higher productivity, and decreased overall health costs. There are a couple of you on this call who we will be talking to specifically about plans we have for wellness moving forward. Just putting a bow on things, a reminder that SEBO does employ a single point of contact method to handle all our customer service issues, which means we prefer that you, the client, and your employees contact our account managers and our service representatives. I'm sure many of you are familiar with AJ and Molly in our office. Our account managers are tailored to support you from the time of the initial consultation all the way through the renewal to ensure that your plan meets the current and future goals. That's also where my job comes into place as well. Why work with SEBO? We do provide COBRA compliance, Section 125 administration, HIPAA compliance, and FMLA compliance, so Family Medical Leave Act compliance. We find there are a lot of employers that are struggling with how to implement Family Medical Leave Act. We do complete an annual market comparison and analyze the current market trends each year with all carriers that are available. We only work with A-rated carriers, and we are a Tier 1 broker with United Healthcare and a Platinum-level broker with Anthem, which gives us access to some products and services that not all others have access to. We do have dedicated account managers who are there to work with you and your group administrators, and we work with your group to establish a long-term wellness goal. We also do things like generic medication comparisons, network provider listings, and facility listings, because we want to make sure your employees are utilizing their benefits as well as possible. We will also provide your employees with specific and personal assistance with chronic illnesses as well. I think just about everybody here is already working with us, but if there is anybody that is not, here's just a quick list of the items that we would need to provide you with a no-obligation quote on your business. That is our webinar for today. There have been a couple of questions, I think a couple of which we've already answered, but there was one in particular that I did want to answer. The question was about an organization that has a policy in place that does not include offering insurance coverage to spouses or dependents. And the question was, will an entity have to offer spouses and dependents coverage in the future? The question is, the answer, is no. You will not have to. You will not be required to offer coverage to spouses and dependents. If that is your policy, you will be able to maintain that policy. In fact, we are seeing a lot of employers, and we will work with you to create such a form. But we have a lot of employers that are providing an affidavit to their employees to be signed by their spouse's employer, showing that they are not eligible for coverage before they would be allowed to come on your group plan. So you will not be required to, and you are not required to contribute anything towards the cost of the insurance for spouses or dependents as well. Again, just a reminder that this presentation is available to you. Please contact Corey Koch or myself. The email is listed below. If you'd like to have a copy of this presentation, as I mentioned, we'll be on Facebook and Twitter posting updates about future webinars. I believe our next one is scheduled for in roughly 2 weeks, 2 to 3 weeks. So we'll have information out there on that. We hope